thank you everybody for coming. So we're going to go ahead with the last of the EM-CCM Conference. I'm going to present to you a pretty interesting case, and then we'll talk about something that you probably don't realize that you know, but I'm going to define it in a few different terms and see how you can apply it to the way that you approach your patients. So we're going to talk about a 45-year-old male whose chief complaint is abdominal pain and vomiting. So thank you, obviously, for the EM-CCM team. So let's start with the pre-hospital history. Chief complaint was abdominal pain. He was at home. He had not been feeling well for the past couple of days. He called 911 because he felt like the pain was getting worse. He had been vomiting all day. He's been unable to eat anything. He just felt terrible. So we called 911. EMS got there. They did initial vital signs. They did note that his heart rate was actually pretty elevated, around 120 beats per minute. BP was in the normal range at 119/71. Didn't seem tachypnic and respiratory distress. And from their documentation, he seemed alert, oriented, was talking. He was just complaining of abdominal pain, kind of lying on the floor. So EMS noticed that he had a little elevated heart rate. They documented actually 2 times in there that it was 100 mLs. So I'm not sure, it seems like a very small amount of fluid. So I think they meant a liter, but couldn't really confirm that. They checked a finger stick on him. It was 83, and they then did an EKG for his tachycardia. The EKG, and in presence of the upper abdominal pain as well. The EKG just showed sinus tachycardia. After the fluid bolus, prior to arrival at the hospital, his heart rate had gone down to 100/5. The BP was essentially unchanged, and the vitals were unchanged. So now he arrives at the hospital. He comes in through ambulance triage. At this point, he actually is alert. ABCs are intact. He doesn't look in any significant distress. So he actually gets triaged over as an ESI-3 over to pod A. These are the triage vital signs. I'll let you take a look at that for a second. So the heart rate at this point had improved down to 90 beats per minute. BP, not remarkably different, but slightly lower than the prior BP from EMS. Still no respiratory distress, and glucose is 34. So at this point, he's in A. He's been there for about an hour, and he gets seen by one of the providers in A, and we get a little bit more information from him. So he tells us, yes, it's abdominal pain. It's what's been bothering him. He's been having this for 3 days. He just has persistently been vomiting, not being able to keep anything down. He feels very dehydrated. He feels terrible. That's kind of why he called. He does admit to daily ETOH use, and he describes the pain as this like generalized abdominal pain, no specific exacerbating or relieving factors. He just feels terrible. On the review of systems, some pertinent positives is that he does just note that he had some weight loss. He also does endorse diarrhea during this time, so some loose stools specifically, but it wasn't quantified further than that. And then he has quite a few negatives. He has no hematemesis, no hematochezia, no melena, no significant skin changes as far as we know, and then no chest pain and no respiratory symptoms. He also has no other referred pain or any other radiation of his pain. And so a couple more information about his past history. When you look through the chart, and the provider documented this as well too, that the patient had really just a couple of visits over a year ago, mostly for some gastritis type symptoms, and dehydration. Was actually placed on observation about a year ago for similar symptoms for dehydration. And then he also endorsed no history of pancreatitis, no history of HIV. He does use alcohol and he drinks, but he's never had any significant ETOH withdrawal or any admissions at our hospital for that. Takes no medications and he has no allergies. Otherwise, in terms of social history, we actually got that he's an MTA worker, he's not formally employed, he's not homeless or anything, but he does admit to drinking pretty regularly. Family history is unknown. So at this point, we have a few things, and we're just going to talk about a preliminary problem list, because as you know, obviously for an EM-CCM case, this guy isn't that sick yet, but something else is kind of going on. So I'm going to go to the juniors at this point. Who wants to give me a preliminary problem list of a few things that you can have? Or that we have it now. Go.
So abdominal pain, vomiting, ETOH use.
Okay.
Diarrhea.
Okay.
Weight loss. Do we have any medical problems or fees?
No other medical problems. What about from his vital signs? I know in the ER he's okay, But from pre-hospital, what did we see? Tachycardia. Okay, so that's pretty much kind of the main things that we got at this point. So initially, for the provider, some initial interventions were done. I'm just going to go through kind of what the providers did. Does anybody want to mention one or two things that they might have done for this patient initially? What you might have thought about based on the information you had now?
Labs, antibiotics.
Okay, we'll get to the lab and stuff in a little bit. How about any like medications or stuff to treat his symptomatology now? Okay, any fluid or anything?
He seemed a little bit low blood pressure, right? Depending on if he's a big guy or a skinny guy.
Okay, fair enough.
Blood pressure.
Fair enough. So the initial preventions that went through, the patient, and we'll get to on the physical exam, looked a little bit dehydrated, and so they did give 2 liters, or ordered 2 liters of fluid at that time. Gave some GI medications of famotidine and Zofran. An EKG was ordered, and other labs were ordered, but specifically a VBG was ordered as well. And so now we'll kind of go through the physical exam of the patient. He was described by the initial provider as a little bit cachectic, kind of thin appearing, speaking and verbalizing complaints, and no obvious distress otherwise. On the HE&T exam, they noted anachoric sclera, very dry mucal oral mucosa. They did kind of seem to portray that this patient was pretty dehydrated on their exam. And then they specifically did comment no thrush. On the cardiovascular exam, no pulses specifically were documented, but there was documentation that the patient had no evidence of JVD, and otherwise an unremarkable cardiac exam. On the abdominal exam, where you suspect to find more of the findings, the patient did have tenderness, kind of mostly prescribed by the provider in the mid-abdomen. No specific organomegaly, no CVA tenderness, no back symptoms, and they did do a GU exam which noted normal genitalia as well. On the extremities and skin, they noted some skin darkening on the lower extremities, but didn't comment much else on that. The skin was noted to be dry, jaundice, unremarkable from that point, but no real comments on whether it was cool, clammy, anything. And then lastly, neurologic. The patient was oriented, speaking, talking. It was mentioned that this patient was talking a little bit slower. It's lower to respond to normal, but it didn't seem incredibly altered, but something to point out. Otherwise, the neurological exam was grossly intact. Okay, so at this point, I'll show you. At this point, you're going to start to get some results back. Okay, so remember we initially ordered some fluid for this patient. We ordered the VBG, and some other labs were ordered at that time. But the VBG, since blood gas is going to come back pretty quickly, so you receive this blood gas while you're looking at the body. So Molly, you want to interpret that blood gas for me?
pH is a little bit low.
Okay, so the pH is low. Okay.
The lactate is very, very high.
Okay.
The gap is also very high.
Okay.
I don't know what the baseline creatinine is. Somebody doesn't have
Okay. Well, we can get into that. Yes, the creatinine is elevated. And one other thing I'll add without going into it because I don't want to take too much time is that the PCO2 is normal, but it's not very much in evidence of any respiratory compensation for this acidosis that's going on, so that's something to keep in mind. But kind of overall, your general impression of this patient's like acid-base status, what would you say?
Metabolic acidosis for the
Yeah, absolutely, with maybe some respiratory component of inappropriate compensation for whatever reason at this point. But we need a little bit more information to really say that. And then this high lactatemia likely contributing to high NAG acidosis. Okay. So you also, at this point, receive a chest X-ray, as the patient had a chest X-ray ordered a little bit before. And so this was all done a couple hours after the patient's initial arrival. I'm not going to go through the details of this. It was read pretty unremarkable, except there's a decently larger gastric bubble on that side, but some low lung volumes, and radiology and the providers didn't comment much else otherwise. So At this point, the patient is reassessed, obviously after the initial laboratory values that came by. The patient was felt to be a lot sicker than they initially were impressed, and that the mental status was not as well off, especially at this point. And so the decision was made, especially with the evidence of the severe acidemia and possible underlying process, that this patient would be transferred to CCT. So the next set of repeat vitals that were done about 4 or 5 hours after the initial presentation was when the patient got to CCT. So these are the vitals in CCT. We see that the blood pressure is 156/11, heart rate's a little bit more elevated, 94, but around the same. A little bit more tachypnic at this point, with a respiratory rate of 22. However, the patient is now noted to be hypothermic. It doesn't mention specifically where this was reported at this point, but I don't think it was a rectal temp at this point. And then another repeat set of vitals were done about an hour after that, noting hypotension, or not significant, but decrease in his blood pressure at this point with the OK map. And then heart rate is elevated to 110, still having some respiratory distress, still a little bit hypothermic, but now SpO2 ranging from 91 and 92% on room air. Okay. And so at this point, the decision was also made to repeat another blood gas. And I just wanted to remind you that the patient had received 2 liters of fluid initially in the ER, because they were ordered for those 2 liters. They did feel like the patient was initially dehydrated. And then once the lactate was drawn and the status of the patient, they felt that they wanted to add a couple more liters of fluid as well. And then the VBG was repeated, and this is at around 10 o'clock, so about 4 or 5 hours after the initial one, with a pH slightly improved, but still very acidemic, 6.953. PCO2 is not very much changed. The bicarb is still quite low, and the lactate's not significantly changed from before, but a little bit lower. So there was not ultrasound documented as far as I could tell. I spoke to some of the providers, and this case was actually a while ago, last year, so I don't have those full details, but if it wasn't documented. Not urban, actually. But we'll get to the further testing in a little bit. Okay, so obviously we have a lot more information, and kind of this is where I want to focus our differential in this case, and we'll kind of go from there. So we'll start with the juniors, and then if anybody has anything in particular that we want to add in for a differential as to what's going on, we'll go from there. Just to summarize real quick, so it's a 45-year-old male, past medical history, not really significant, but does use some daily alcohol. He comes in initially complaining of abdominal pain. He now has noted severe acidemia, lactic acidosis. He's now hypotensive, hypoxic, with a worsening mental status, and is transferred to CCT at this point. So what are some differentials that we have? Okay.
Alcoholic.
Okay.
Gram-negative sepsis.
Okay.
Mesenteric ischemia or something like that.
Yeah, so some type of sepsis. Okay.
Severe pancreatitis.
So,
Pancreatitis.
okay, pancreatitis.
Toxic alcohol.
Toxic alcohols, okay, some type of ingestion as well.
Cyanide.
Okay.
Bowel obstruction.
Okay. So we can kind of lump them into a few categories. Any other particular differentials anyone wanted to throw out there? Okay, so we can kind of lump them into a few categories. Y'all name almost everything that I was thinking initially. I'm sure this is probably not comprehensive in terms of what's going on, but based on the picture, just wanted to create something. So, obviously the definition of shock is a little bit more, but I think we can assume that this patient is probably going in that direction. And so I lumped them all into a category of under-distributed shock, so some of the causes that may be causing that type of either septic shock or distributive shock. So mesenteric ischemia, severe pancreatitis, some type of perforated viscus, cholangitis, this patient's having abdominal pain. Also could be cardiogenic shock as well too. We don't really know exactly what's from there. I didn't have an EKG at this point. Definitely alcoholic ketoacidosis, ruptured AAA. With the hypothermia going on, considered hypothyroidism, but a little bit less likely with the rest of the picture. And then we included metformin just because with the severe lactic acid elevation, we have to think about other things like toxic ingestions or things that would specifically cause that lactate to rise without necessarily being specifically related to perfusion itself, but might just be caused in lactic elevation. So just to kind of go through the ED course a little bit, at this point, the patient had now received a total of 5 liters of fluid. 2 liters of it was NS initially, then 2 liters of LR, and the patient was receiving a 5th liter of fluid of isolate. A bear hugger was placed given the hypothermia. The decision was made, especially now that the BP started to drop in, was to place a central line because everybody felt that this was likely some type of distributive or septic shock. The patient was ordered for norepinephrine and then broad spectrum antibiotics with vancomycin were ordered as well. And so at this point, the patient was persistently hypotensive, worsening mental status. Respiratory rate was still elevated, showing some signs of respiratory distress now, with persistent hypoxia down to 92-93% on room air. So what further testing would anybody want to do? I know we haven't gone through the labs, but let's to focus on our specific differential, just name a few tests that we would consider. Okay, serum osmolality.
LEMP, blood center.
Okay, lipase, CMP, blood cultures, so some type of infectious etiology. Anything else?
CTA.
Okay, CTA for, okay,
Aspirin.
I'm sorry?
Aspirin.
Aspirin, okay, as an aspirin overdose, so an aspirin level, so some type of tox overdose levels as well. Anything else, anybody particularly? As a consideration? As consideration, okay. So for further testing, we'll go through the initial labs that were ordered. So CMP, lipase, CBC, TFTs were also ordered, and then infectious workup was ordered as well. In terms of other imaging, CT abdomen pelvis was ordered. This had actually been ordered a while ago because the initial impression from the original provider was to always get a CT abdomen pelvis initially, but couldn't be performed or anything yet at this point because of the patient's status. Critical care medicine consult was placed as well. So let's kind of go through some of the results. So these are the laboratory values that we have up here in terms of the CBC, CMP, and some of the other ancillary tests. We also do get coags as well, which would be something. So specifically, we would, in addition to the BMP, we would really want to look at more of like a liver function testing type aspect as well. So do you want to point out some of the abnormalities on here?
Yeah, so lipase is elevated. You have like an alcohol picture.
Okay.
ST, 3 times high, 5 times high.
Okay.
TW mildly elevated, phosphates really high. 7. Otherwise, there's like an anemia, like a macrocytic anemia.
Yep.
With a TOH boost. It's creatinine is 3.4.
Yep.
Glycar's still 4.
Yeah, PTT is a little bit elevated as well. Absolutely.
It's
So
on the lower end.
yeah.
It's mild anion gap,
Yes.
just a small one.
Just a small, just a little anion gap. So I do not have actually serum osmos for this patient, but that is definitely something that I would consider in this patient as well. We do know that the lipase is markedly elevated, and we are getting a picture of some potential effect of alcohol as to what's going on in the underlying cause of this, so alcoholic ketoacidosis, alcoholic hepatitis, definitely pancreatitis at this point, especially given the patient's presentation and the lipase level. And then there's evidence that maybe the patient drinks a little bit more than we think that the patient drinks initially. The TFTs were also performed as well. So the TSH was 0.922 and the free T4 was a little low as well. So at this point, kind of more of a sick thyroid picture. And then a UA was performed which showed 3+ protein trace ketones with no significant evidence of any WBCs and a little bit of some RBCs. And so the CT abdomen and pelvis was also performed. And I'll just kind of have it run through this real quick. I'll do it twice. I would focus on the pancreas. And then also look at the colon, specifically the ascending colon. Okay. Does anyone want to see it again? Or?
Yeah.
Okay.
The temperature broke. Is that a temperature broke?
I don't remember that. I have to look. At this point, yes, the patient did have rectal thermometer. Should have had, because they were trying to warm the patient pretty aggressively. All right. Okay. So just to kind of talk through without going into crazy detail, the pancreas is definitely showing some evidence of inflammation and everything around it, consistent with pancreatitis. And then we are also seeing in the cecum and ascending colon, there's a lot of bowel wall thickening, as well, consistent with some type of colitis. Okay, so now we have an updated problem list at this point. Our initial differential is probably pretty close to what's going on. At this point, we feel like it's most likely some type of distributive shock. The patient definitely has pancreatitis, has laboratory physical exam and radiographic evidence of it. Also has colitis, noted on the physical exam. And if you do remember, the patient did endorse having some diarrhea over this time, non-bloody, but definitely persistent volume. And then we have some evidence of alcoholic hepatitis as well. There was a beta-hydroxybutyrate ordered. It was not, it just says collected, it was not resultant. So I can't tell you exactly what the ketones were at that point, but there were some ketones in the urine. And then there was not a significant other intox workup done initially at that point as well too. So just kind of go through the ED course. We have, this is about 8 hours after the patient initially arrived. While the patient's in CCT, almost immediately after the patient had received the central venous catheter, the patient started to have generalized tonic-clonic seizure, was ordered for 4 milligrams of lorazepam. Following that, the patient persistently became hypoxic, bradyed down into bradyasystole. No pulse was felt during this time as well, and so CPR was started. The patient received 1 cycle of CPR with epi, calcium, and bicarb, given knowing the prior acidosis and everything as well. And ROSC was achieved immediately from that. The patient was intubated, placed on 450 milliliters of PRVC at 15 breaths per minute with a peak of 5 and FiO2 of 100%. And then the patient was ordered for fentanyl and midazolam for sedation. And then just to show you, after this is post-intubation chest x-ray as well. That large gastric bubble is still there. No major consolidations, as we can see as well, but a little bit of more pulmonary congestion and prominence of the pulmonary vasculature at this point. There's an ABG done post-ventilation. And so it was about maybe a little over an hour to 2 hours after the patient was intubated and ventilated. So the pH is normalized at this point to 7.347. The patient is also on pressors at this point as well too. The PCO2 is a little bit lower now. The patient started breathing over the vent at a rate of around above 20s. And then the PaO2 was 181, which this was still at 100% FiO2, so pretty low PF ratio at this point. The bicarb started coming up as well. And then just to kind of show you, because obviously all of these VBGs and ABGs were ordered as shock panels, the lactate was trended during this time. It was almost every like Q4 hours. Initially was 21, then 18, and then now that the patient is not as acidotic anymore, there's still an elevated lactate of about 8.7. The patient was still persistently hypotensive despite the levofed that was on. So vasopressin was added at 0.02 units per minute. The patient was transferred to MICU at around this time and then switched in the MICU from Precedex. And then in addition to the levofed and vasopressin, epinephrine was added as the patient was still requiring high doses of levofed, and was still persistently hypotensive. And then the MICU also ordered hydrocortisone, 100 milligrams Q12, which was then later on switched to 50 Q6, but initially started off. So our resulting diagnosis that we have for this patient at this point was shock due to severe pancreatitis and colitis, more specifically distributive shock, most likely, especially. So what am I going to talk to you about? I'm going to talk to you about a term called vasoplegia. Has anyone heard of this term? No? Yeah. So you know what it is, and I'm going to explain to you what it is. They're just defining it in the literature in regards to the concept of distributive shock and septic shock as the more underlying pathophysiology as to what could be contributing to what's going on to the patient. So we'll define that for you. So I'm going to define vasoplegia. Why it's important to kind of talk about it is that just so that when we go forward with further studies, we're kind of like using the same terminology. And then we'll kind of understand the underlying pathophysiology behind it. I'll talk to you about kind of vasopressors. We'll review some of the literature on it. And then we'll talk about, very briefly, adjunctive therapies and some experimental stuff that's kind of going on. So what is vasoplegia? It's very simple. It's the concept that a patient has low systemic vascular resistance in the presence of a maintained or increased cardiac output. So you can imagine that that would lead to some type of shock state and hypotension in the patient because the peripheral blood vessels and arterioles are not constricting as they should in response to the hypotension. And so subsequently you get hypotension. And it's kind of more thought of as the loss of vascular tone. One thing it's not is it's not neurogenic shock. Neurogenic shock is still obviously, or like a neurogenic cause, it's still obviously its own entity, specific with a different pathophysiology related to the loss of innervation. So what causes it? Pretty much everything that you can imagine causes a distributive shock is going to cause vasoplegia, because vasoplegia is like an underlying mechanism of distributive shock. And another term for distributive shock is vasoplegic shock. So sepsis, any type of severe inflammatory state, such as pancreatitis, severe burns, significant trauma. And then one entity that I want to mention specifically is any surgery can, but specifically cardiac surgery. And the main reason that that is the case is because one of the actual interventions that you do during cardiac surgery, cardiac bypass, does actually lend itself as a predisposition to this state of vasoplegia and some type of distributive shock state, which we'll talk about in a little bit. And then the main thing that I want to talk about it is because the basic science behind it is intracellular and extracellular effects that prevent the vascular tone from being there. So the intracellular effects we'll talk about on the next slide. And the extracellular effects, just want to briefly mention that it's in addition to the hormones, the catecholamines that are going around, but also the neurological system that's giving you feedback in terms of. So I created this little diagram. This is very simplified in terms of the pathophysiology as to what's going on. But if I put up the pathophysiology, I would bore you to hell and it would not be very interesting. But I just wanted to kind of boil it down into this concept so that we could, when we talk about some of the therapies that we're giving, why people start thinking about adjunctive therapies that sometimes seem ridiculous and also may or may not cause any type of effect on the patient. So here we're talking about the fact that this patient has some type of tone, and it's the vascular state exists in hemostasis, so you're trying to maintain a specific perfusion pressure so that the body can do its normal functions. So we have central neuro and hormonal control, so that's the specific neuronal innervation of the vasculature, as well as hormonal control in terms of things like steroids, not specifically the catecholamines, but other type of circulating hormones, angiotensin, things like that, that will affect vascular tone. And then down here I've kind of coupled into quote unquote inflammatory process. It's way more complicated than that, and it's, if you think it as this simple, we'll probably be overthinking things, but it's kind of where some people are coming from in terms of why some of these other therapies work. And specifically I want to mention nitric oxide. So if you remember FERCHGUT, if you went to downstate here, realized that he received the Nobel Prize for discovering nitric oxide as one of the mediators for vasodilatation. So that pathway is actually still specifically used or understood in this type of pathological state. So nitric oxide does have a role, and I'll show you a little bit as to why that happens and why some of the therapies are considered in refractory shock in this type of case. And then obviously vasopressors are directly acting on the vasculature in order to constrict the blood vessels to respond to the catecholamines, which is where the mainstay of our treatment for this is. So now we're going to go into something a little bit more interesting in terms of like, what are we going to do about it? This is what we're interested in, right? So we're going to talk about different vasopressors. And I'm just going to leave this up for a second. I'm not going to read through everything, but the main point is the vasopressors, obviously they're not all equal, right? And we know that. And they act on various different receptors. They have different affinities to the different receptors. But the reason that they respond to these different receptors is the reason why we get different effects going on with it. And one of the things that you want to think about, so our mainstay that a lot of people are using currently for a very good reason is norepinephrine. It has alpha activity, and alpha activity is where we get all of our vasoconstriction primarily from in the periphery. It has some inotrope activity with the beta-1, and it doesn't have any vasodilatation. And so the vasodilatation is actually a big aspect as to why dopamine does not, is actually been shown to be causing an increase in mortality in patients who receive it in septic shock. A big part of that is one, when you have vasodilatation in response to the constriction, it's not like the blood vessels, all the big blood vessels are opening and closing at the same time. It's that the like microcirculation has a very different effect. And so that's stuff that we don't understand very well, but there's still some basic science going on in that. But because of it, in order to maintain the same perfusion, your body has to work harder. So to maintain the same cardiac output, you often have to be more tachycardic, right? Cardiac output equals stroke volume by times heart rate. So that's why you see this like dysrhythmias as well as significant tachycardia in patients on dopamine. You can see that with dopamine too, but it doesn't have any of the alpha activity, so it's kind of what they call an inodilator. So it has a little bit of the dilatory effects with beta-2. And then vasopressin, I put it in here because it is a pressor and it does act at one of the receptors, but I like to think of it less as compared to the others, because the others are more specifically like catecholamines. Vasopressin has its own specific receptor, and it mostly works in like the splanchnic circulation and constriction and that, rather than more globally. So now that we talked about the different pressors, that they all have various different aspects, when do I add pressors? And this question is obviously there's no solidified answer to this at some point. But if you look back at the literature as to what's been going on, initially people were like, okay, with early goal-directed therapy, we should be giving patients this 30 cc per kg bolus in sepsis. And then, after the Manny Rivers trial, we realized that probably wasn't necessarily the case that we needed, and so we started to do other trials, and namely process trial, various other things, which actually showed that, standard of care and conventional care was not any better than early goal-directed therapy, which as we probably know. So if you look at the current sepsis guidelines, they still recommend 30 cc's per kg of fluid bolus. And if you, does anyone want to guess why? Not guess, or if they know why we still want to give fluid? Okay?
Fill the pipe.
Okay, that's a good rationale.
Administrators don't read the literature.
All right, there you go.
Is the question, why do you theoretically give fluid?
So it's why do you theoretically, and why do they still recommend it?
Well, theoretically, you give it to increase stroke volume.
Right, okay. And then what about why is it still recommended specifically? Because we actually showed that even in patients who didn't receive this specific early goal-directed study in the process trial, they still recommend the fluid bolus.
Just because we haven't found anything better.
Yes, that's exactly it. So the data, no one has really specifically looked at, how much fluid you need to be giving this patient before. We just kind of said it's a very good understanding rationale that the patient oftentimes is fluid responsive and might need some fluid before. And there are some early studies that also showed that when you started adding pressors specifically norepinephrine early, that the mortality was a little bit higher. We'll talk about that in a little bit, but it's not very clear that that's the case. The main point is that the rationale behind it is not that you have to give fluid before. The rationale behind it is there may be some benefit of giving fluid before, and you should definitely consider it, but whether you need to be giving 30 cc's per kg is not necessarily definitive at all. You need to be giving enough fluid to have fill the tanks, as we talk about, increased stroke volume in the Frank-Starling curve, which we'll actually talk about in a second. And then, this whole concept, obviously if you're waiting too late, the patient is in a shock state for much longer, and you're increasing mortality. And there's actually some studies that show that if you waited more than 6 hours, 8 hours before you even gave pressors, obviously the mortality went up. And then I mentioned that too soon, some of the earlier studies, if you didn't give any fluids at all, and you just gave pressors, some of these patients had an increase in mortality. That may not be the case, and we'll talk about it a little bit later. But the consensus is most likely you should be adding pressors very early as you can consider it. And it's still reasonable to give the patient a fluid bolus to see if they're fluid responsive first. And how much you should give that's up in the air. So we'll talk about, before we get to the Frank-Starling relationship, we'll talk about norepinephrine at this point. So raise a hand, who would consider norepinephrine the first line choice? I know it says it up there, but
Yeah.
almost everybody, right? So the rationale behind that is secondhand. So one, we've done some studies, and there's a Cochrane review that compared all the pressors and sepsis, and to determine which one is better. Their conclusion was that there isn't very good evidence for it, but if they had to make a recommendation, norepinephrine seemed to cause the least side effects and the least mortality and problems associated with it. And one of the effects that people theorize norepinephrine might have that benefits it, especially over dopamine, is this lack of a disconnect between the vasodilatation and the cardiac inotropy. And so you get inotropy with Levophed, and you don't get that with dopamine as well. And so that's something, so early on, you're getting a little bit of extra increased contractility in the heart, which overall is helping the cardiac output. And then one thing that we do know about norepinephrine is that high doses are bad. So I'll ask 2 more questions. Does anyone know what they would start Levophed at? 5, okay. Okay. Anybody else have any different answer? Okay, you can. Is there any rationale for what we're starting it at? Not really. I mean, there are recommendations in the doses, and it had it up on the prior one. From looking at the literature, from what I can tell, it's kind of still more of a consensus recommendation. 5 is, I think anything lower than 5 is probably too low. You can certainly start a little bit lower, but a lot of people are still recommending actually you can go from 8 to 12 as an initial starting point of Levophed, and then titrate it from there. I mean, its effects are pretty effective. And then in terms of high dose, does anyone know what you would consider a very high dose of Levophed?
You get a ceiling effect somewhere after 10, between 10 and 20 days.
Okay. So it's interesting that you actually mentioned the ceiling effect. So that's kind of what's theorized, and a lot of hospitals also prevent you from using Levophed above 30. And I've actually encountered that a couple times here, although specifically downstate, that actually has shown that you can use much higher doses. And the mortality effects and the adverse effects of Levophed much higher than 30 isn't really shown until you get to what's effective for the average person of about 70 kilograms of a Levophed dose of like 80, 60 to 80. That's when you start seeing effects. So in terms of the ceiling effect, I couldn't really find any specific data that really supported it. In animal models, you don't really necessarily see it. But we, of course, can't just, portray that, but that's some rationale to think about it. But the point is that very high doses, just going up and up and up and up on Levophed probably is not the answer. You need to start looking at other things. So that's what's going to bring me to the Frank-Starling curve on this aspect. So why are we giving fluids? Why is inotropy good? Why is Levophed a little bit better of a drug that works? And the rationale that that most people consider is if you actually look at shock, septic cardiomyopathy, so a reduced cardiac function and contractility of the heart, is present in almost, the data is terrible for this, but somewhere between 40 and 60% of patients with septic shock also have some contribution of decreased contractility and decreased cardiac output just from heart failure. And so whether that's clinically relevant, that is still a little bit up in the air, and there's some more recent studies in the past couple of years that have tried to look at that, which we'll talk about. But it is present and it's there. And if you sono these people, you'll see that oftentimes they do have a reduced function in the heart. And if you talk about our patient on day 2 of hospitalization, somewhere between day 2 and day 3, this patient definitely had a reduced EF. On a formal echo that was performed at the bedside, the patient had areas of isolated contractility in the left ventricle, as well as an EF of about 40 to 50%. So there's some aspect of that. And then the main reason that I talk about it is, so left ventricular end diastolic pressure, which is kind of your correlate for CVP, because that should equal it. And it's also important to think that when that pressure gets really, really high, that's associated with cardiogenic edema, right? So if we're giving too much fluid and we fill the tank too much and the fluid's going around to the left side of the heart, the left side of the heart can't pump it out, at some point we're going to be getting cardiogenic edema. And that effect is higher when the heart isn't pumping as well. So obviously giving a lot of fluid to these patients can end them up in pulmonary edema. And one of the things that I want to mention is that this patient received 5 liters of fluid. Then they started showing signs of hypoxia, started showing signs of ARDS with the reduced oxygen level on the blood gas and the reduced PF ratio, as well as some signs of pulmonary congestion. So I didn't have a bedside sono for this case, but you could consider guiding sometimes your therapy by looking at the patient's heart, seeing are you showing signs of clinical signs of pulmonary edema, or looking at the lungs. Not just the contractility of the heart, but looking at the lungs. We know that ultrasound just for looking at fluid status is not great. But there are some definite correlates between IVC and depending on the patient's status and the patient's CVP and the likelihood of them having an adequate fluid status. And so should we be adding more inotropes? This is, as I was mentioning, it's like, why is levofed better? Maybe it's because the inotropy is good. Should we add dopamine? The general consensus from people is that you should, but there's no evidence really to back that up. Only reason I mention is because not all shock is equal. Maybe there is some underlying cardiogenic component to it, but studies that have looked at septic cardiomyopathy, in which you try to add, you recognize it and you add some type of inotrope, they don't really show improved mortality. There were some initial studies that showed that maybe they stayed in the ICU less and the length of their shock state was less. But it didn't really match up to any specific patient-centered outcome.
So just as an FYI, there's Germany and a couple of other European countries will actually use epinephrine as their first-line pressor, mostly because they hang their hat on a couple of non-inferiority trials that showed that the mortality between epi and Norepinephrine was essentially the same, but that epi was cheaper. So from a single-payer health system perspective, they chose epinephrine. So it's a reasonable first-line pressor, but I think so you can do both because things about that.
Yeah, absolutely. And one thing that, and they did specifically talk about this in some of the sepsis guidelines, is that epinephrine, because it is catecholaminergic more than levofed, is going to increase your lactate, which may not actually have any effects. And we are very obsessed with lactate kinetics and using that to guide. So, we're still trying to use goal-directed therapy regardless of the fact that we aren't really 100% sure if it's working, especially more in the specific critical care side. But you're absolutely right. And they do mention specifically that epi is a very decent choice. And, I don't have levofed on the floor, but epi is in the cart. So that's probably
So you
usually what I'm
going
going
to
to
do
use.
drip, for example. I know it's not a great term to use, but
Yeah.
if you need a pressor right then use it.
Yep. All right, so I gotta go because we're almost a little bit out of time. So now I just want to talk about adjuncts. So vasopressin, there's a lot of studies because the interest was maybe vasopressin is better than Levophed early. One of the big studies that kind of suggested this was a post-cardiac surgery study in which they looked at, compared just, randomized controlled trial, Levophed and norepinephrine for these patients with hypertension, or Levophed and vasopressin for these patients with hypertension after. That vasopressin actually showed an increased mortality effect, less side effects. So they tried to look at it in sepsis, and there's two big trials, the VAST and the Venous trial, that showed that it was pretty non-inferior. And so, I think that the rationale for using vasopressin as like an additive agent exists a little bit more, because the idea that you could reduce the amount of Levophed that you have to use, or the other type of pressor you have to use, could be useful. And it also does have different effects, right? It's splanchnic circulation constriction, more so than a lot of the other pressors. But it does also have its own side effects, and it's very similar, like mesenteric ischemia is a real side effect, but these are pretty rare. And in the VAST and Vanish studies, they showed that when you compared the vasopressin groups and the Levophed groups, the adverse events really weren't any different at all. But in the Vanish trial, Levophed had a trend towards more adverse effects than vasopressin. And then corticosteroids, which is a very fun topic for everybody, right? I talked about that whole inflammatory state. So some of the pathophysiology behind it is the steroids, one, reduce a lot of the cytokines and receptors that lead to this low systemic vascular resistance. It also potentially upregulates receptors and makes you more responsive to the pressors. So people are very excited to add that. The initial trial, some initial trials showed that, maybe you should do that. The adrenal trial was the first trial to look at this, and it showed no effect of adding hydrocortisone. Yet still in the sepsis 3 guidelines and in sepsis 2, they still recommend in refractory shock. They're like, the harm's not that bad. Maybe you should consider it because the data isn't 100%. So there've been a couple more studies that came after that. Corticus was another trial that looked at it and said, okay, we can do the study better. Maybe we can find more specific effects. And they still showed no mortality difference, but they did show decreased length of stay in the ICU, decreased length of catecholamine use, so secondary measures that don't really relate specifically to mortality. And then the more recent trial, which is the Approach trial, in which they looked specifically at hydrocortisone and fludrocortisone along with another drug during that time to see if it had a mortality benefit. And patients who had hydrocortisone and fludrocortisone did well, but it did not compare it just to hydrocortisone as alone. And one thing just to know about it is that the mortality in that study compared to the other two, which had about a mortality of about 30%, the Approaches trial had a mortality of like 40 to 50%. So maybe you could see more of an effect in these sicker patients. So I don't think it changes any of the practice. I probably wouldn't start it necessarily even in the ER, but if patients are very refractory, it's still something that I would probably use. And then whether you need to add fludrocortisone or not, just hasn't been studied yet. It needs to be studied. But the basic science behind it suggests that it might be beneficial. Next, I want to talk about methylene blue. And so you're probably like, what? Why would we use methylene blue? This patient does have methylene blue anemia. But specifically, methylene blue inhibits nitric oxide. And in patients who had cardiac surgery, it showed that if you gave a patient methylene blue who had a distributive shock after cardiac surgery caused by the bypass, they actually did significantly better. And there's a mortality benefit. They didn't have to use pressors, and things are great. So people said maybe we should use it in sepsis. However, it hasn't really been studied significantly well, and there are mortality effects and adverse events associated with it, because as you can imagine, methylene blue is just inhibiting all nitric oxide. And nitric oxide isn't just used in blood vessels. And so we don't know enough about it, but it should be considered, although it's not really well used. I would argue it could be considered in pretty refractory states, but not all shock is the same. And we do know that a shock that's very inflammatory might benefit. So maybe in the pancreatitis state where it's not really full sepsis, would it help? I don't know. I can't really answer, but it's just something to think about. And then the experimental stuff, which everybody's probably heard about in the news a few years ago with thiamine and vitamin C, where Merrick did a trial that showed that basically cured sepsis by giving patients thiamine and vitamin C. And it came from the concept that patients in sepsis have low vitamin C. One thing I'll say about that is the studies that vitamin C levels are low in sepsis, have actually been shown that that's not really the case. If you measure it in a different way, it's probably normal. It's just the effects of sepsis cause vitamin C to be low. And then thiamine is like a cofactor in a lot of different aspects, and it's a big cofactor in conversion of pyruvate into acetyl-CoA, which allows you to do aerobic metabolism. So that's a big thought as to why for adding it. The important thing to know is that there are a lot of trials going on for it because it's received a lot of press. So people kind of threw money into it. So there's 2 big trials, and one coming where they're putting thiamine and vitamin C, starting it in the ER for patients with sepsis. So it's just something to look out for and to see. We'll see if it actually has an effect or not. And then some of the more theoretical stuff is centra alpha-2 agonists. We mentioned that patients who have this central modulation of their vascular tone, when you give them pressors for a long period of time, they don't actually respond to the pressors very well after a certain amount of time. And the thought is that the body is out of homeostasis and it's trying to correct that with the central system, and that alpha-2 agonists could actually prevent that and allow you to use pressors less. So this is where some people have said maybe we should be using Precedex, because one, it doesn't cause significant hypotension, just bradycardia, and it might be beneficial in this, but this has not been proven at all. But it's something to consider, especially rather than using propofol or other drugs that really do make you a little bit more vasodilatory. And then the last 2 I'll mention is esmolol. So there's some studies going on right now in the same concept of the alpha-2 agonist is actually adding a beta blocker, short-acting beta blocker, to these patients with the other pressors that are going on. And there's some basic science studies in animal models that show that this is protective, and maybe it has something to do with the cardiogenic aspect of the shock as well. But their main theory is that it's kind of central. And then angiotensin 2 is just a different pathway of pressors. It hasn't really been fully studied, but they're also looking into it as well. And so, we can kind of summarize everything that all these adjunctive effects are trying to work in a mechanism that we don't really fully understand yet, but we're getting into the research into it, and it is pretty fascinating, and maybe at some point we will understand why people do have this vasoplegic state. And I just want you to think of vasoplegia as an aspect of this patient's condition, rather than it just being shock. So maybe there's other stuff kind of going on than just, oh, this patient has sepsis, I should do these things. And then I just want to kind of summarize the rest of the course. The patient had a C. diff that was sent in the ER that was positive, so they considered it to be a community-acquired C. diff colitis in addition to the pancreatitis. Possibly all of this was exacerbated by drinking and everything as well. He was started on CVVH because of persistent fluid overload, basically. During the next couple of days, he was oliguric actually in the ER. He never made urine. They put a Foley in, they got like 10 cc's out. And so he was actually never making any urine the entire time that he got there, even before he was put on pressors. And then once they got a lot of fluid off, they actually took the CVVH off after about 4 days. He was extubated, downgraded to the floors, his AKI was resolving. He was discharged to subacute rehab. He actually followed up in renal clinic, in cardiology clinic in February, and he has normal renal function. He has no heart failure symptoms or anything anymore. He's actually completely fine, and he has no other kind of sequelae from it. So it's a really nice outcome for the guy. It's good from there, but it was an interesting case to kind of look at what were the contributing factors to his sepsis. So in summary, yes, I think you should give fluids. People should get a bolus as to whether they are fluid responsive, and whether that is the case or not is a whole nother topic that we're not going to go into. But don't wait for more fluid before you start adding pressors. The sensor trial actually kind of came out a week ago that showed that starting, it was a phase 2 trial, very small, single center, randomized control trial, but starting low dose Levofed, so lower, around the 5 mics we were actually talking about, early, like talking about within an hour and a half, as compared to when most people started, which is about 2 to 3 hours, that it showed a mortality benefit. So, there still needs to be more studies on it, but it's definitely, fluid resuscitate, start your pressors early, and you should use Levofed. And then I would advocate for, using ultrasound, using other assessments of the patient to see, what is the patient's hemodynamic status? Is there a cardiogenic component as to what's going on? Because yes, we want to improve mortality, but if we don't have to have the patient end up on dialysis forever too, because their kidneys aren't shot, that's also still clinically important and important for the patient as well. And then add another agent early so you're not getting all the deleterious side effects of one agent. And then obviously there's a lot of other stuff going on. So I know I kind of went over time, I apologize.
That was really good.
Thank you. But any specific
Could you
questions?
kind of maybe talk about like propofol use of like prophylaxis?
So a lot of these studies, most of the patients receive pressors either, about half, a little over half received pressors centrally, but a lot of them received it peripherally as well. So there wasn't, a lot of people would argue there's not really a big difference between that. And in the sensor trial, about 40% of the patients used peripheral fed. So something to think about.
I just had a question for the attendees. Is there any reason to have dopamine ever?
Right now, the only time it's probably recommended is in bradycardia, the American Heart Association, for bradycardia causing shock that's not responding to atropine, and if you don't have a pacemaker, you can try the catecholamines. And those, you can either try dopamine or epinephrine.
Yeah.
That's the only thing now. That's in a different situation. That's to increase heart rate more and bring up the pressure that way, rather than as a pressing agent.
Yeah, and I think, like Susie, we talked about that as well too. I think in bradycardia, that's still a good use for it. But with every
Dopamine, at a low dose, it's a vasodilator.
yeah, absolutely.
And, if you started at a low dose and blood pressure is marginally, you drop the blood pressure.
Yeah, it is dose
I
dependent.
think that's why epinephrine is a better drug to use bradycardia.
I agree. And we also oftentimes, and this is like for the EMIs as well too, like when you're on the floors, you don't know the full picture of the patient. You don't really know what's going on. Epinephrine is probably a much better choice to cover your bases as to what's going on, and even if the patient's bradycardic. So.
Also, when you intubate really sick patients like this, you should always have a syringe of epinephrine at the bedside.
Yes.
Because this happens a lot. When you intubate very sick patients, you increase intrathoracic pressure, decrease the system return, and they arrest. And the way to do it is to give a small dose of epinephrine right when you're intubated.
I just want to say how terrific that presentation was from giving the presentation. You knew your stuff so well, you didn't have to look at the slides except to know which slide was up, but then you didn't read from them. You used your audience, you got people involved, you spoke well, you gestured well, you made great eye contact. Your slides were very, very readable.
Thank you.
When you did use the font, it was big font, and you didn't use more than about 5 or 6 letters across and 5 or 6 lines down. I just thought it was a terrific presentation, especially how well you knew your topic.
Thank you.
That really impressed me.
Yeah, so we should go to Wingate Park right now.
Stephanie said you would probably ideally go through the department, to Kings County, go out the back door, and do not go to the track, go to the high school on Kingston.
Della, I checked you in. Della, I checked you in.
Yeah.